Okay, hello guys, very good morning. I hope you people are there and waiting for this class. This YouTube session I kept for the important MCQs and the related topic for the FMGE exam, which is going to happen in August 2020. So, I hope you are prepared and not facing any problem. Currently, the revision is as we say, key of success. Revise your important subjects, the basic and minor subjects. Apart from that, important obs gynae and the important points of PSM. These are the important one subjects. And be relaxed, sleep properly, take good food, and remain calm. This is a key of success. So now just revise things, but not be so much in hurry, and revise particularly which you made as short notes, so in less time you can revise more. Okay, so let's start. We'll go through MCQs, and along with MCQs we will have the important points to of that topic. I will tell you. If you have any query, please ask me so I can answer. Okay, so let's start. Okay, so Encastic personality disorder. Feature of an Encastic personality disorder, we have procrastination, rigidity and stubbornness, lack of impulse control, none of the above. So in this just important area, I will tell you personality disorder they are asking. So I will revise briefly the every personality disorder they are going to ask about it. So please remember that we have obsessive compulsive personality disorder. In DSM we call it a obsessive compulsive personality disorder, and in ICD we call it a Encastic personality disorder. So obsessive compulsive personality disorder DSM, and Encastic personality disorder is ICD. Okay, ICD. So the same obsessive compulsive personality disorder we call it an Encastic personality disorder in ICD. What are the symptoms? These people have a problem of perfection. Because of perfection, they do the delay in work. They are very rigid in their work. They are very stubborn. So they are very stubborn, very rigid, they have a delay in work, and they have a problem of perfection. That's why they have a delay in work. This is one of the personality disorder. PD, they are always target. So one MCQ you will think like you already prepared. So briefly I will tell you about personality disorder, PD. We have cluster A personality disorder. In cluster A personality disorder we have schizoid, we have paranoid, and we have schizotypal. Schizoid person is alone, always prefer alone, no friends, patient is indifferent to praise and criticism, indifferent to praise and criticism, no friends, solitary activities. So these people always prefer alone. Whether you are praising them or criticizing them, they are indifferent to that. They don't have much friends. They always prefer solitary activities. They don't prefer the activities in gathering. And whether that's why they otherwise also they don't get married, because they are not interested in sexual relationships. So either they don't get married, if they get divorce. Paranoid, very suspicious people, very suspicious. Fight for rights. They think that other people interfered in their life, otherwise they would have achieved so much. Paranoid, so suspicious, fight for rights. Schizotypal. In schizotypal, only personality disorder where patient has minor illusion and hallucination. Minor illusion and hallucination. And OC symptoms, obsessive compulsive symptom. So this is the only personality disorder where we have minor psychotic symptoms in form of illusions and hallucination and obsessive compulsive symptom. Apart from that, philosophical ideas, superstitious things. That's why, remember, it's a very important MCQ that in ICD and DSM. In ICD, schizotypal we count under psychotic disorder, and DSM we count under personality disorder. So in ICD we count under psychotic disorder, in DSM we count under personality disorder. Okay. Okay. Cluster B. In cluster B, we have narcissistic, borderline, narcissistic, borderline, anti-social, and histrionic personality disorder. Sometimes they can ask, all of the following comes under cluster B except, or personality disorder they ask one MCQ. That's why I'm little talking in detail. Narcissistic person think that he is very unique, he is very special, you have to admire him. He is very special, very unique, require admiration. I am the best. Narcissism, narcissistic personality disorder. Borderline, they have very unstable relationship. 1 minute they think he's my best friend, second minute they think he's my best enemy. That's why there is a frequent history of suicide. If you do their physical examination, they will have over the marks over the hands, wrist, the slashing wrist. So these are the frequent history of suicidal attempt. And in borderline, remember one more thing, they have a history of depression. Histrionic personality disorder, they use physical appearance. They use physical appearance to draw attention. They use physical appearance to draw attention. Their way of talk, their color of cloth will be different from others. They want a center of attention. If they go to the party, they want that people should, they want a center of attention. This is a histrionic, easily suggestible, easily seductive, histrionic personality disorder. Antisocial, कानून तोड़ने के लिए बना है, antisocial. They have a frequent history of jail. They come out from jail, do some fights, some panga, again go to jail. Frequent history of jail and no sympathy, no empathy towards people. Antisocial. Then we have a cluster C. In cluster C, we have dependent personality disorder. We have OCPD, obsessive compulsive personality disorder, which we just recently discussed, and anxious avoidant. Dependent, as the name suggests, patient is dependent on others for every decisions. So for every decision, patient is depend on others. This is dependent personality disorder. OCPD we discussed. Independent patient can't take any decision on his own without the helping of others. So it's not about boyfriend, girlfriend. If they have a friend, if they had a breakup with the friend, the first thing they will do, they find another friend whom they can be dependent. Anxious avoidant personality disorder. Anxious avoidant. They think they are inferior to others. They are not socially, like up to the mark. They think that people will criticize them, people will show them inferior. That's why they, unless they know someone very well, they don't go to the parties. And so this is anxious avoidant personality disorder. Inferior to others. Dependent, OCPD, anxious avoidant. Correct, guys? Cluster C. Okay. One we have type A. Type A, very competitive, very hostile, very aggressive in their approach. Workaholic people, we say in layman term, workaholic people. They have increased risk of ischemic heart disease because always they are under stress. And we have a type D. We call it a stress related personality. If they don't have a stress, that is stress for them. That's why they don't have a stress. This is type D. But remember, type D personality is a most common type of personality which increases the ischemic heart disease. So type A having a risk of ischemic heart disease, but type D is a most common type of personality which having a increased risk of ischemic heart disease. So cluster A, cluster B, cluster C, type A and type D personality. Okay. This is the question number 1. I hope you covered it. Second is, so question number 1, answer is B for Bombay. Second is first and symptom of Schneider. They ask, so first we'll I will write down first rank symptom, and then I will come back to the MCQ. Many times they ask the name in your FMGE exam, that what are the first rank symptom. First rank symptom, the court Schneider has given the first rank symptom. What are the first rank symptom? He has given the 11 symptoms. There were total in 11 symptoms in number. He told that even single symptom is there for 1 month, we can make a diagnosis of schizophrenia. So much importance given to these symptoms. That's why we call them top rank, first rank symptoms. And they are thought insertion, thought withdrawal. So thought insertion, thought withdrawal, thought broadcasting. Thought insertion, thought withdrawal, thought broadcasting. Thought insertion, thought withdrawal, thought broadcasting. Broadcasting. Thought insertion, thought withdrawal, thought broadcasting. Third person hallucination, discussing type. Third person hallucination, commenting type. So third person hallucination, discussing type. Third person hallucination, commenting type. And the sixth is thought echo. Thought echo. Third person hallucination, discussing, commenting, and thought echo. Next is mad affect, mad act or volition, and mad impulse. And we have mad impulse, and we have delusional perception and somatic passivity. Delusional perception and somatic passivity. These are the 11 in number. Even you don't know, we have discussed in various classes. You can go through one's theory, but at least you have to remember the name of these first rank symptom. They ask one symptom, they ask all of the many times this MCQ. Like this MCQ, you will see that all of the following are first rank symptom except. So we have running commentary of one's thought, yes. Primary delusion, yes. Somatic, so delusional perception, we call it a primary delusion. Somatic passivity, yes. Depersonalization is not a first rank symptom. So many times they ask this MCQ that all of the following are first rank symptom except. So the option A is the answer in this MCQ. Okay guys. In narcolepsy, the polysomnographic recording typically shows which of the following pattern. So in narcolepsy, I will just briefly tell you because they are nowadays asking lot of MCQs about narcolepsy. It's a very important area, narcolepsy. Male-female ratio is 1:1. Onset is second decade. We have tetrad of narcolepsy: sleep, attack, sleep paralysis, sleep attack, sleep paralysis, cataplexy, and hypnagogic hallucination. So sleep attack, sleep paralysis, cataplexy, and hypnagogic hallucination. Hypnagogic hallucination. Sleep attack, paralysis, cataplexy, hypnagogic hallucination, tetrad of narcolepsy. In PG they ask, in your exam also they can ask nowadays. So we have a two type of narcolepsy, type 1 and type 2. This is a very important MCQ. So we'll just once go through it. Type 1 and type 2. In type 1 we have narcolepsy with cataplexy, and type 2 is a narcolepsy without cataplexy. So narcolepsy with cataplexy is type 1, narcolepsy without cataplexy is type 2. The hypocretin level will be low in type 1. In type 2 it will be normal or high. That's the two important differentiating point between type 1 and type 2 narcolepsy. That please remember, very very important point. These are, maybe they will ask in your this August wala exam. Narcolepsy with cataplexy is a type 1, narcolepsy without cataplexy is a type 2. Hypocretin level, which is a important chemical, we see that responsible in the narcolepsy, which decreases in hypothalamus. It decreases in hypothalamus. In type 1 it's a low level, and in type 2 it's a normal or high. That you know, that if they ask you the drug of choice is modafinil. Modafinil is a drug of choice of narcolepsy. Okay guys, so see the MCQ. Recording typically shows which of the following pattern in an absence. So narcolepsy is a REM sleep disorder. It's a REM sleep disorder. So an absence of REM sleep in mid-cycle, no. Spike and wave EEG recording, extreme muscular relaxation, typically shows REM intrusion during inappropriate period. So there is a atonia, but it's not like extreme muscular relaxation. It's not extreme. So the option A will be right. There is basically it's a REM sleep disorder. So what happens, in the REM increases in narcolepsy, and because of that REM intrusion will be intermittently during inappropriate period, and that's why patient has a sleep attack, patient has a sleep paralysis. Okay, and sudden, we have the decreased muscle tone and paralysis, cataplexy. So option A will be the right answer in question number 3. Question number 4. A young male is started on high medication, injectable haloperidol of 5 mg twice a day. Patient develops tongue protrusion and impaired swallowing. The treatment is stop the medication, conversion disorder, reduce the dose of antipsychotic and give propranolol, and give anticholinergic, antihistaminic drug. So what's the diagnosis? As I told you, this MCQ, that this area they target again and again. So please remember, if you make a diagnosis, it's a acute dystonia. In acute dystonia, we have a involuntary movement of neck muscle and neck, facial and jaw muscles. Involuntary movement. Patient will have a torticollis, will have a tongue protrusion, patient will have a muscles of, the ocular muscles, ocular gyrus. We say this is an acute dystonia, it's an acute side effect. In this case, what we give, acute side effect, we give treatment of immediately. If you want to give the injectables, we give the injectable intramuscular promethazine we give. Phenargan injection, which is very popular, the name is Phenargan injection, we give intramuscular promethazine. Apart from that, in tablet form we can use bench-hexol and trihexylphenidil. Okay, trihexylphenidil and bench-hexol. In injectable form we give intramuscular injection promethazine, or we call it a Phenargan. Okay. Otherwise also in side effect they can ask you this question. They ask very common, that most common side effect of typical antipsychotics, that it's a akathisia. What is akathisia? Sometimes they ask the definition of akathisia. Patient having a subjective complaint of inner restlessness. Patient will say, sir, since you started me medication, I am not able to sit at one place. I am moving around, roaming around everywhere. And if they ask you drug of choice of akathisia, propranolol, beta blocker, propranolol is a drug of choice of akathisia. Okay. Apart from that, another side effect of antipsychotic we have, and the extrapyramidal side effects or Parkinsonian symptom. Basically, by giving antipsychotic, we decrease the level of dopamine, and by decreasing the level of dopamine, we create an artificial picture of Parkinson disease, and because of that, patient having a extrapyramidal side effect or Parkinsonian symptom. Otherwise, Parkinson disease we treat with the dopamine agonist, but antipsychotic induced Parkinson disease we treat with the same anticholinergic drugs like benzoxol and trihexylphenidil. Okay. So otherwise you go through my notes. The side effects again I am telling guys, it's a very important area. They ask again and again. Just remember one important MCQ that they can ask you in pharma, that one of the side effect of antipsychotic is what? Tardive dyskinesia. It's a more chronic side effect. Patient should receive at least 2 months of antipsychotic. Then patient having a tardive dyskinesia, patient having a perioral movements, especially perioral movement. That's why we call it a rapid syndrome. It's a very common in a middle-aged female. The important point I want to tell about this domain is that before we did not have medication for tardive dyskinesia, but recently we have a FDA approved medication, valbenazine and tetrabenazine. Valbenazine and tetrabenazine is a recently FDA approved treatment for tardive dyskinesia. Okay, yeah. So if you'll see the answer in this MCQ, stop the medication. No, it's conversion disorder, so no treatment is required. Option B, that's also wrong. Reduce the dose of antipsychotic and give propranolol. No, it's not akathisia. Give anticholinergic antihistaminic drug. Yes. So question number 4, answer is D for Delhi. Next is, which of the following the most common cause of delirium in the elderly people? It's a substance abuse, it's a accidental poisoning, hypoxia, use of multiple medication. Yes, in elderly people, use of multiple medication is one of the cause of delirium. One of the cause of delirium. Delirium, they ask very frequently. So what important point they can ask in delirium? In delirium they can ask it's a most common organic disorder. It's the most common organic disorder. They ask that there is a disorientation to time, place, and person. Very important and cardinal feature of delirium is what? Impairment or clouding of consciousness. There is a memory deficit. Please remember, there is a deficit of immediate and recent memory. Please remember, the remote memory is intact in delirium. It is intact in delirium. In delirium, we have the transient or fragmentary delusion. Transient or fragmentary delusion. Basically, patient, because of fluctuation of consciousness, there is a fluctuation in delusion. Delusion sometimes is there, sometimes is not there. We call it a transient or fragmentary delusion. Transient or fragmentary delusion. Okay, transient or fragmentary delusion. Next is patient having a visual hallucination. There is a perceptual abnormality, patient having a visual hallucinations and illusion, and there is a sleep-wake cycle disturbance, sundowning phenomenon. That word they can ask you, sundowning phenomenon. As the sun sets, as the sun downs, patient condition get worsen. This is a sundowning phenomenon seen in delirium patient. Okay, so compared to morning and afternoon, in evening patient condition get worsen. That MCQ, please remember, the easy finding in delirium is patient will have slow wave easy. Slow wave easy. So all delirium patients have slow wave easy. The background activity of easy is slow wave, except alcohol withdrawal delirium and benzodiazepine withdrawal delirium. In these two delirium, we have fast wave activity. Fast wave activity. So that you have to remember. Another name of alcohol withdrawal delirium is what? Delirium tremens. Delirium tremens. And if they ask you the treatment of delirium, guys, the treatment of delirium is treat the cause. Treat the etiology. Treat the etiology. Treat the etiology. The benzodiazepines are contraindicated in delirium except these two conditions. Which one? Alcohol withdrawal delirium and benzodiazepine withdrawal delirium. In these two conditions, the drug of choice is only long-acting benzodiazepines like chlordiazepoxide and diazepam. And along with that, we give the low dose of haloperidol. We give low dose of haloperidol. Why we give low dose of haloperidol? To calm down the patient, because one of the symptom of delirium is what? Increased psychomotor activity, but treatment is treat the cause, treat the etiology. Okay, so delirium also very frequently asked topic. Briefly I told you the every point of delirium. So in this MCQ the answer will be D for Delhi. Question number 5, answer is D for Delhi. A case of schizophrenia is characterized by extreme posturing, negativism, rigidity and mutism. The best treatment for immediate response is. So typical antipsychotic, atypical antipsychotic, modified ECT, both typical and atypical antipsychotic. So if you'll see the MCQ, that this is a case of posturing, negativism, rigidity, mutism, that it's a case of catatonic schizophrenia. And in catatonia, for immediate response, what we'll give the ECT, electroconvulsive therapy. So answer will be ECT, modified ECT. Answer is C for Calcutta in question number 6. C for Calcutta. So briefly, what they can ask you about schizophrenia. Schizophrenia, guys, it's an important area. They touch it. So one is, remember that in this is a new question they can ask, that in DSM 5 and ICD 11 we have no subtypes of schizophrenia. So before we were categorizing schizophrenia: paranoid schizophrenia, hypophrenic, catatonic, simple, undifferentiated. Now schizophrenia is schizophrenia according to DSM 5 and ICD 11. There are no subtypes. Subtypes have been removed. That one point you have to remember. And in catatonia also, please remember, catatonia is a these lines you have to remember: separate diagnosis in ICD 11. In ICD 11 we have a separate diagnosis of catatonia. Catatonia related to mental conditions and catatonia related to associated with the psychoactive substance. So this is a separate diagnosis in ICD 11. These lines you remember directly. If they ask, it will be useful. And in catatonia we have many symptoms like echolalia, echolalia, repetition of words or sentence heard by the patient; echopraxia, repetition of action; patient having a rigidity; patient having a negativism. Negativism is passive resistance to all movements. Apart from that, patient having a catalepsy or flexibility, catalepsy, maintaining a normal posture for long period of time. And posturing is maintaining an abnormal posture for long period of time. Mcqs, patient having Mcqs, excessive movement with the slight pressure. And MB tendency, patient having a MB tendency, confusion regarding the action. And Gegenhalten. These are the signs and symptoms of catatonia. Etiology of catatonia is not properly known, but in treatment it having a very tremendous response to what? Lorazepam. And if patient is not responding for lorazepam, we go for electroconvulsive therapy. These points you have to remember about this topic. So it's a very important area they target it. Okay, the important points I already told you. So question number 6, answer is C for Calcutta. Early morning awakening is characteristically seen in endogenous depression, anxiety neurosis, mania, neurotic depression. So answer will be endogenous depression. So you know we have somatic syndrome, we divide the mild depression, we divide the moderate depression, and we divide the severe depression. In moderate depression we say with somatic syndrome and without somatic syndrome, with somatic syndrome and without somatic syndrome. And severe depression we say with psychotic symptoms and without psychotic symptoms. So what is somatic syndrome? the somatic syndrome is patient having a early morning awakening, early morning awakening, depression. More patient is suffering from somatic syndrome. Somatic syndrome shows the severity of the depression. Currently we call it a somatic syndrome. Previously we used to call it a melancholia, melancholic depression. And these symptoms we have in a endogenous depression. In endogenous depression, please remember one important point, that we had endogenous, previously we were saying that psychotic symptom we have only in a severe depression. Currently, according to ICD-11, we can have psychotic symptom in moderate depression, also in a severe depression. So psychotic symptom we have in a moderate depression, also we can have in a severe depression. Okay, so previously we were saying that psychotic symptom, if they are there along with depressive symptom, always diagnosis is what? Severe depression with psychotic symptom. First time ICD-11 claiming that psychotic symptom along with the severe depression we also can have in a moderate depression. Okay guys, the next is, so question number 7, answer is A for apple. 8. A 19-year-old woman is hospitalized for dehydration for laxative use. She admits that she is using laxative, binge eating frequently and worried about gaining weight. Although the woman is very thin, believes that she is overweight. She has never had menses. Which of the following disturbance is the most likely? Patient having a gain weight, and there's the binge eating. So it's a usually we have a diagnosis in this we have, it's a eating disorder, we have anorexia nervosa and we have bulimia nervosa. So usually the binge eating followed by compensatory behavior, usually we have in a bulimia nervosa. So if you'll see this area also they ask nowadays very frequently, eating disorders. So be very carefully that in bulimia nervosa, patient has a binge eating food more than the usual at a given point of time and followed by compensatory behavior. Binge eating and compensatory behavior. Binge eating and compensatory behavior. So eating more than the usual and compensatory behavior. Okay. Compensatory behavior. Compensatory behavior is use of laxatives, using of enema, self-induced vomiting. This is compensatory behavior. And we have anorexia nervosa. In anorexia nervosa, 3 important points. The BMI currently according to ICD-11 it is 18.5 kg per meter square. Before we were saying less than 17.5, or body weight of the patient is less than 85% of normal weight. This is the one criteria. Second criteria, 3 months history of amenorrhea, 3 months history of amenorrhea. And the third important criteria is body image disturbance. Despite being a thin, patient thinks that she is very fat or bulky. Why I am saying she? Because male female ratio is 1:10. It is almost in female. Now remember one new MCQ. 3 months history of amenorrhea criteria has been removed in DSM-5. That's a very important point. So before we were saying that 3 essential criteria for anorexia nervosa: body weight less than 85% 5%, and 3 months history of amenorrhea, body image disturbance. But DSM-5 removed this 3 months history of amenorrhea criteria. That the new question you should know. Then we have complications of anorexia nervosa and bulimia nervosa, that you once go through the theory. Important points I told you. If they ask you about the treatment is CBT, cognitive behavior therapy, we use in a eating disorders, and we use cyproheptadine. It's a appetite stimulant in anorexia patient, because persistent taking a less food, they have a decreased appetite significantly in anorexia nervosa patient. Okay guys, the next MCQ is, so question number 8, answer is C. Which medication is used for treatment of nicotine dependence? That you know. Answer is what? D for daily bupropion. So in nicotine dependence, you should know nicotine dependence is very substance use they ask very frequently. The nicotine dependence, one of the fastest addictive substance, nicotine dependence. What treatment we use in nicotine dependence? Please remember that we have a decreased concentration, we have a irritability and bradycardia. Please remember, we all withdrawal, all the substance having a tachycardia as a withdrawal symptom. Nicotine dependence has a bradycardia as a withdrawal symptom. What treatment in nicotine dependence we use? First is we use NRT, nicotine replacement therapy, which comes in a gum form, in an inhaler form, patch form, lozenges form. It doesn't come in a tablet form. So nicotine replacement therapy doesn't come in a tablet form. Bupropion, which we use as an antidepressant, which is of norepinephrine dopamine reuptake inhibitor group. And the third drug we use varenicline, which is alpha 4 beta 2 partial agonist, which is alpha 4 beta 2 partial agonist. Alpha 4 beta 2 partial agonist. Okay, alpha 4 beta 2 partial agonist, varenicline. So this is the varenicline. The side effect you have to remember, it's a suicidal tendency. Side effect of a varenicline they can ask. So question number 9, answer is D for daily. Question number 10, a 32-year-old woman is diagnosed with major depression. What is the chance that her identical twin sister the same disease? So it's the answer is 70%. Identical twin 70%. So see how the genetic loading we have, how much genetic loading we have in a psychiatric disorder. Otherwise, you remember in a depression, if otherwise we have, if one parent suffering from depression and both parents suffering from depression, one parent chance of depression in children 10 to 25%, in both parents suffer chance gets double, and identical twin chance is up to 70%. In general population, the prevalence of depression is between 5 to 17%. Very high prevalence in general population. So question number 10, answer is D for daily. Question number 11, a man feels that his nose is too long, friends feels otherwise. He has consulted 3 plastic surgeons, treat him, suffer from which condition? So it's like patient feel the friends feel otherwise, but patient is convinced about it. He even consulted 3 plastic surgeons, so conviction is very high. So that I told you that they always give the both options, hypochondriasis and delusional disorder. In this question, answer will be delusional disorder. In this question, answer will be delusional disorder, or we call body dysmorphic disorder. body dysmorphic disorder, or we call delusional disorder, delusion of dysmorphophobia. We call it a delusion of dysmorphophobia or body dysmorphic disorder. In this patient, some body part look ugly. So patient is very convinced about it. In hypochondriasis, patient will think about some problem in his or her body, but there is a fluctuation of conviction. You show some investigation, you explain the patient will agree with the facts. So in hypochondriasis, the basic difference between body dysmorphic disorder and hypochondriasis, that there is a fluctuation in conviction in the hypochondriasis, there is no fluctuation in the conviction in the body dysmorphic disorder. So guys, in this MCQ, answer will be D for Delhi. Another name of hypochondriasis in DSM-5, we call it a illness anxiety disorder. Remember that. Somatization, it can't be Munchausen syndrome, it's a factitious disorder. Patient present the symptom intentionally. So it's a really different diagnosis that already we have discussed in many classes. A 25-year-old female was brought to the casualty after she allegedly attempted suicide, reached less, past history of maintaining interpersonal relationship problem. And what is the most likely diagnosis? Most likely diagnosis will be, already I explained you in personality disorder, that unstable relation, frequent history of suicide and mood fluctuation. They have a history of depressive episodes. So answer will be B for Bombay, borderline personality disorder. PD, personality disorder, is a very important topic they can ask you. So free association, in free association, what patient does in free association, the Freud has given the free association. In this, the patient reveal his thoughts freely to the therapist. So this is one of the technique given by the Freud. So in Freud, you have to remember this. Freud, in your exams usually they don't ask about the when he born, but he born in 1856 in Czech Republic. Most of the time he spent in Austria, and in 1939 he died in London. He has given the topographical model in 1900, and he has given the structural model in 1923. Okay, about Freud, psychosexual stages also you should know that we have a oral stage 0 to 1 year, we have a anal stage 1 to 3 year, we have a phallic stage 3 to 5 year, we have a latent 5 to 11 year, and we have a genital 11 year and further. We have a schizophrenia and substance use disorder diagnosis if the patient having a fixation in oral stage, in anal stage OCD, and phallic stage dissociative disorder. Just remember it directly. He has given the technique, we call it a free association technique. The patient used to sit in front of him. He did not interrupt the patient. Patient used to tell about symptoms to Freud, and once patient would have completed, then he used to interpret and making diagnosis. We call this free association technique given by the Freud. He also, the one thing they can ask you, defense mechanism. Just remember at least they can ask you in defense mechanism, sometimes they ask that what are the mature defense mechanism. You just remember the name: altruism, anticipation, asceticism, and asceticism, altruism, anticipation, asceticism, humor, and sublimation. At least you remember these 5 mature defense mechanism, and they ask again and again in various exams, including FMGE. So question number 13, answer is A for apple. Question number 14, Capgras syndrome is more commonly seen in what? Schizophrenia, in psychotic disorder. So in paranoid schizophrenia, I explained in many classes, but now just remember that we have Capgras syndrome, we have Capgras syndrome, and we have Fregoli syndrome. In Capgras syndrome, just remember, familiar person replaced by unfamiliar person. And in Fregoli, opposite, unfamiliar person replaced by familiar person. So familiar person replaced by unfamiliar Capgras, and unfamiliar person replaced by familiar is Fregoli. Okay, Fregoli. So Capgras syndrome and Fregoli syndrome. Okay, yeah. We call them delusion of double because we are talking about two people, familiar, unfamiliar, or unfamiliar, familiar. We see in a paranoid schizophrenia, question number 14, answer is B for Bombay. Question number, we have a patient of mania was started on lithium therapy. After 1 week, there was partial improvement in the symptom. Serum lithium level was 0.5 milliequivalent. What will be the next best step? So please remember, the prepare and plan dialysis. Why on 0.5? So sometime read, I request you read the MCQ very carefully. Even reading MCQ with the common sense, you will do many MCQs. So I request you guys, do this thing in your exam. Don't be panic. Whatever MCQ is there, whether you know or you don't know, sometime reading MCQ calmly will give you the answer. So see option A. Why you prepare and plan the dialysis if the level is only 0.5, it is below than the normal, add the second drug to the lithium. Why we have to add when we have to optimize the dose of one drug first, then the maintain same dose and monitor. We should not maintain the same dose because the usual level of the serum lithium level is what, 0.6 to 1.2 millimole per liter or milli equivalent. So increase the dose of lithium. Yes, we have to increase the dose of lithium. So suppose even you don't know this MCQ, by reading the options carefully, you will get the answer. So lithium is very important drug. You have to know about lithium. In many classes, lithium 100% you will get the one MCQ. So briefly, I will tell you about the lithium. The important points what they can ask about lithium is, so number one, that when we check the serum lithium level, we check after 4 to 5 days, particularly fifth day. We check the serum lithium level 12 hours after last dose. So suppose on 5th day you want to check. When you will check, you ask the family member, give the morning 9 a.m. lithium, give the 9 p.m. in night lithium, and then after 4th day, on 5th day, before giving the drug, before giving the lithium, you check the level around 9 a.m. in the morning. So we have to check the level after 12 hours of last dose of lithium. Okay, yeah. The important side effects, we have endocrine side effect, that hypothyroidism and hyperthyroidism. We have a renal side effect, nephrogenic diabetes insipidus. Treatment we give is spironolactone and amiloride. And we have the cardiac side effect. Cardiac side effect is T-wave flattening, and it is contraindicated in a sick sinus syndrome. 3 important organs are affected in the lithium. That's why we do the thyroid profile as an investigation, we do the renal function test, and we do the ECG. The other common side effects of lithium are ataxia, diarrhea, acne, psoriasis, memory deficit, Okay, the important one, the increased TLC leukocytosis. That's why it is contraindicated in a that's why we use in a treatment of what, neutropenia and cluster headache. The teratogenic side effect of lithium is abstain anomaly. Abstain anomaly. Abstain anomaly. Teratogenic side effect is abstain anomaly. It's a tricuspid valve atresia. We have abstain anomaly. Please remember, it's a anti-suicidal mood stabilizer. That MCQ also there. So some or other thing they are going to ask about the lithium serum, lithium level in acute phase and in prophylaxis phase. So in acute phase we use 0.6 to 1.2 millimole per liter. In prophylaxis we use 0.6 to 0.8 millimole per liter. So acute 0.6 to 1.2, prophylaxis 0.6 to 0.8 millimole per liter. 0.8 millimole per liter. Okay. Yeah. This all they will ask about the so this is one of the session I prepare I brought for you. Two or another session before your exam I'm bringing. So through these sessions, 3 sessions, we will cover almost every important topic of psychiatry. Two consequent more sessions for FMG are there. So please be aware about the timing. Just see the schedule and I will bring the 2 more session and I will complete the psychiatry important points and the important MCQs, and so you will not have any difficulty in psychiatry in this August 2020. Okay guys, so revise, study well. Again I'm saying, be calm, revise your important subjects, sleep properly, it's very important, and remain calm. Now don't worry, you studied and you have to convey this good message in examination hall. For that, only knowledge is not going to the key factor. Your calmness, your approach to the MCQs, how you will approach that also a very important point. So best of luck, see you in the next session. Listen.